Hello, participants. We are, hello, participants. People are joining, and I'm going to give a minute or two for people to get here and join us at the beginning of our October America Walks webinar. Um, for those of you here early, my background is the Washington Cascades, which I managed to sneak out to at an earlier weekend, last sunny weekend of the year. I'm out in Seattle, Washington right now, where I've been for years. Um, and I'll just start sharing a couple of thoughts. I'm really excited about this webinar because, I was a local advocate in my own city of Seattle, Mike McGinn, Executive Director of America Walks. And I remember the very first time I was told that the way to think about traffic safety was the three E's: education, engineering, and enforcement. And I felt like I was now privy to this new little piece of knowledge about how to think about streets. And it made perfectly logical sense, right? That you want to have well-engineered streets, you want to educate people on how to use them, and for people who break the rules, there needs to be some method of enforcing them. But I'm guessing that for all of the people on this panel that are participating and watching this webinar, you probably have a pretty good feeling that those three E's don't quite work. And we've added some E's over time, like you get up to 4 or 5 E's if you want to do something. And as a mayor of Seattle, I was a mayor of Seattle from 2009 to 13, we highlighted the three E's. So I was very excited to see the development of something called the safe systems approach, which really started to try to take a look at how these things interact and with an emphasis on human frailty and weakness, that you could not count on everybody to follow all the rules, that enforcement wasn't necessarily going to be a solution in some instances, and it was undoubtedly an advancement. But then I saw a presentation of the safe systems period by one of our panelists today, Dave Ederer, Dr. Dave Ederer of the Centers for Disease Control. And he had written a paper on the topic of, um, treating it like an epidemic. And how do you think about interrupting the spread of the injury-causing agent? And we've all learned a little bit about epidemics in the last few years, but it also had the benefit of helping one start to prioritize what things really mattered amongst the various elements. So I won't steal his thunder or try to do his presentation, but we're very excited to have Dr. Dave Ederer with us from the Centers of Disease Control to make his presentation on the Safe Systems Pyramid. He's joined by Steph Leonard, who is works for the Colorado Department of Public Health and Environment, and she's a built environment coordinator, herself a transportation advocate over the years, and who's working on implementation within the state of Colorado of the Safe Systems Pyramid, and can add those perspectives as well. I am also joined by my America Walks fellow board member or fellow traveler, Abdullahi Abdullah. He's an elected official and transportation consultant in the state of Minnesota, and like me, has dealt in a hands-on way from the elected official thing, but he's actually a trained transportation professional instead of just a dedicated advocate like me. So having a dedicated amateur. So having said that, that's who this is for. It's both for the trained advocate, the trained professionals, and the dedicated amateurs about how can we advance the ball on traffic safety. And I'm very excited to be able to share this presentation. If you like this, we're very grateful to the Centers for Disease Control, which helps fund this webinar, and our other partners. We are very grateful to those that have donated to us in the past. It helps underwrite this. So go to americawalks.org. You can easily find how to contribute to this in the future. And without these types of independent funds, we can't do all of the great work we do. And you will see a link in the chat if you'd like to donate. So with that, I believe it's my turn to stop. Oh, no, a little bit of logistics. Let me find the right side. There's a Q&A section of the user dashboard please enter any questions you may have. After the presentations, Abdullahi and I will bring those to the fore to be answered by the panelists and to be the basis of discussion. And we might even be able to answer a few in the chat as we go. So welcome, everybody, and let me throw it to Dave.
Thanks, Mike. I really appreciate the introduction. And I'm really flattered to be here with all of you. Just it's Pedestrian Safety Month, getting to present with America Walks, and I also just have a lot of admiration and respect for folks in Colorado and Minnesota. I think, if you're looking for places to learn from, Minnesota and Colorado are a good place to start. So it's really cool to get to speak here with Steph, Abdullahi, and Mike, because it's people and places I've followed for a long time. So I'm really excited. So treating traffic deaths like an epidemic. My job title is epidemiologist, so I suppose I should be able to think about like this issue as an epidemic, but I'm actually trained as an engineer, as a transportation systems engineer. And so on my first day at CDC, I came in as something called an epidemic intelligence service officer. It's our disease detectives. If you've seen the movie Contagion, I think Kate Winslet is an EIS officer. So that's how I came to CDC. And on my first day, going around talking about who they were, what they did, and they would ask what you're trained in, and I said I was in engineering, and the instructor said, "Well, why are you here?" And I wish I'd had this org chart on hand. I wish, it's always good to have an org chart when you're a bureaucrat, but this is one of the first org charts that CDC presented when it was created in 1946. And you'll see that we had an engineering division at the time. Most of these other divisions exist in some shape or form. Entomology, those are diseases associated with insects still exist. A lot of these different places still exist at CDC in some shape or form with similar names, except the engineering division. And I say this because there was a time when we felt engineers, city and community planners were key public health professionals. I think they still are. I hope I can convince all of you that you're part of the public health workforce. You have an important role to play. But I think we in public health have forgotten that it wasn't so long ago that CDC defined itself as a place where doctors, biologists, and engineers came together to alter the built environment to prevent disease and promote health. And that's why CDC is actually in Atlanta, because at the time, you're thinking about the 1940s, we were bringing lots of people to the American Southeast to go off and fight in World War II. And what was a big problem? Malaria. We had malaria here in Atlanta and throughout the Southeast. So we had something called the Malaria War Control Agency. And the goal was to manipulate the built environment to make it difficult for mosquitoes to grow and develop and then transmit malaria to people coming to the Southeast. So this idea that we manipulate and alter the built environment to improve human health is actually why CDC exists. And I think we as public health professionals can think more about how we alter the built environment and apply these ideas to our work. And that's especially important for traffic safety, especially when we're talking about people walking and cycling. So we can change the built environment, not just to make it safer, but to make it to expose people to the benefits of physical activity, which I'll talk about a little bit later in this presentation, because that is also one of your mandates as a public health professional, is to make it safe and easy for people to walk and cycle. Another thing I wish I'd mentioned at the time is that indeed, we didn't just create divisions at CDC where we hired engineers and planners. We were led by an engineer. So the first director of CDC was a guy named Mark Hollis. He was actually an engineer by training. And then if you know the history of NHTSA, the National Highway Traffic Safety Administration, was actually led by a medical epidemiologist. So if you're following along, NHTSA and CDC were both founded with different occupations leading them. CDC was originally led by an engineer, and NHTSA was led by an epidemiologist. And I think that's because a lot of these public health ideas had been prevalent in other occupations, and we've kind of gotten away from it. And I think we should go back. So if you go back and look at one of our major journals, the American Journal of Public Health, people were debating training for a public health engineer. And I really love what they highlighted here. We now recognize public health engineering, and you can put in planning or whatever you want, but we now recognize public health engineering as an essential calling, the prime object of which is to control the factors of the physical environment as they especially affect the health and welfare of aggregates of people. So whether in groups or in cities, states, or other areas, and in the nation as a whole. So the focus there, again, alter the built environment and health and welfare of large groups of people. So it differs from what doctors do, right? Doctors work on one patient at a time. Public health professionals think about the population. And so they even went so far as to describe the coursework for an undergraduate in public health engineering. If you went through formal training in engineering or planning, this might be pretty similar to what you were exposed to. This curriculum is very similar to civil engineering curriculums that you see today, except that there were 2 semesters of transportation. I know where I received my engineering degree, we don't have transportation as a required course, let alone as 2 semesters of it. So way back when in the 1930s, public health engineers were learning about transportation, and I hope that we can get back to that. But beyond just learning about public health and the outcomes associated with transportation, I think it's important to think like an epidemiologist. And one of the classic disease models is something called the epidemiologic triad. So Mike mentioned the E's, engineering, enforcement, education. Those are descriptive models of what's happening. Important sectors to be involved, but it doesn't get at cause and effect. And in public health, we're interested in cause and effect, right? So the classic disease model is another E, unfortunately, the epidemiologic triad. So for any health issue to occur, we need the host to interact with an agent, and they all are interacting within the environment. When those three things come into contact with each other, it creates disease, right? And to prevent disease from happening, we try to disrupt the relationship between one of those 3 things. And later on, we thought about the social determinants of health, and that the interaction between these 3 poles changes depending on the social environment, the social determinants of health. So we can go back to our malaria example. So to get malaria, you need to come a human host, right? To a person, for a person to get malaria. They need to come into contact with any number of plasmodium parasites, right? And typically they do that by interacting with a mosquito that carries that plasmodium. And that mosquito thrives in environments where there's lots of standing water. And if you're a worker that works in South Georgia, and maybe you work near a place where there's lots of standing water, you're a lot more likely to contract malaria than someone who works in an office away from that standing water. So you can see how the host agent and the environment and then the social context all interact with one another to cause disease. And you can apply that to any number of diseases or health conditions. And actually the first the first NHTSA director, William Haddon, that epidemiologist, what he understood was that for injuries to occur, we're still talking about human beings, still talking about the environment and the social determinants of health. But what he understood was that the pathologic agent was energy. So if you think about it, the way an injury occurs is when the human body faces the transfer of more energy than it can sustain. So it's just like a virus or any other pathogen, right? There's a viral load and a dose response relationship. So when there's enough of that virus reproducing in your body, you contract disease. when you're exposed to a large amount of energy, you become injured, right? If I just, touch my wrist, I'm not injured. It's a small amount of force, but if I apply enough force, I can become injured, right? And that is very relevant when we're talking about the transportation system, because there are massive amounts of energy in the system at any given time. And so we do lots of things to protect people inside of vehicles, right? So if you think about 3-point seatbelts, they're designed to dissipate the transfer of energy over portions of your body that are much stronger, right? If you know those older cars that we used to have a seatbelt that just goes over your lap, and what happens? You get launched forward and your head might hit the steering wheel. A much better design is to use those 3-point seatbelts that dissipate the energy transfer over your body and do it in places that can sustain a large amount of energy transfer. It's much safer. We can also tell people to change how they behave in the environment by changing speed limits. Say, well, there's a lot of school children around here. You need to slow down, right? That changes how people behave in the environment. We can also change how we design our vehicles, right? If you think about a car, we do a lot of engineering to make it safer, right? We put in crumple zones in the front and back, and that absorbs the energy, right? You'd much rather total your car than have you become injured, right? It's better when the materials of your vehicle absorb the energy rather than it going to your body. That's why we have roll cages and lots of other interventions to make them much safer. So we can take these ideas and we can implement them in the built environment. It's the same thing, using that pathology, understanding that the transfer of kinetic energy is what actually causes injury should drive everything we do. But we also need to account for human behavior, right? Mike said it earlier, there's humans are imperfect, right? And they tend to try to do things in their own self-interest, right? So we have to think about that human behavior and how people behave. And we also need to prioritize population health impact. We're not physicians. We should be exposing people to safety as much as possible. So it's kind of complementary to medicine. So physicians work on the individual level, and we in public health work at the population level, right? So Dr. Frieden, another CDC director, was, I guess, close to 8 years ago now. He proposed a health impact pyramid where he prioritized population health impact and decreased individual effort. And he proposed this pyramid where we have education at the top and then changing the context and socioeconomic factors at the bottom. This is something I learned a lot from. And if you think about masks, right, that's a very important and protective intervention. But it requires individual effort and lots of people to do it every single time, right, to get that protective effect of masks. So a little bit, you might call that a clinical intervention. Much better than that are vaccines, right? It only acts on the individual level, but maybe you only get it once a year or once in your lifetime, and it's a long-lasting protective intervention. And even better than that is changing the context. Think about how our world has changed when we think about sick leave, right? If we're sick, I think we're far more likely, at least at my employer, to stay home from work after the pandemic occurred. We changed the context in which we work so that we decrease that transmission of disease. And that, even better, if we're changing the socioeconomic factors outside of just one employer and all employers, imagine how much safer and healthier we would be if we were able to change how we think about work and staying home when we're sick. We'd have massive effects on our culture and public health. And so that gives us a sense of priority, which we were missing. Mike mentioned it earlier. When we think about the E's, they're just alliterative and descriptive. They don't tell us anything about prioritization or cause and effect. So I took ideas from the health impact pyramid, something called the hierarchy of controls, which you might be familiar with if you've worked in occupational health or engineering. And we prioritize population health impact, and we prioritize those things that require less individual effort. So we can tell people all day that they need to slow down, right? And we can educate them on the benefits of slowing down. That doesn't do much when our built environment is telling them to speed up in their car, right? Education can only get you so far if all of the other feedback we're getting, whether it be from our vehicles, our coworkers, or the built environment that we're in, if it's telling us one thing, we're going to respond to those larger incentives in the built environment or in those active or latent safety measures. So active measures are things that require individual effort, but are still very effective, right? So you can think about seatbelts, extremely effective, but you have to put it on every time to get that safety effect. It's a little bit better to have that latent passive safety happening at all times. Crumple zones in our vehicles are a really good example because we don't have to turn crumple zones on in our car. They're always on. We always get that safety benefit. Even better is altering the built environment to get people to slow down, make it easier to walk and cycle, because that intervention is long lasting. It's always there, and it should influence the entire population. And long term, changing our culture, having the socioeconomic values where we create safer environments and worlds. I think about land use and planning here. Imagine if we didn't have to drive so far, right? If we didn't have so much sprawl, we wouldn't be exposed to that high level of system kinetic energy, right? And we can talk about more examples later, but I want to get to our key points here. The public health approach prioritizes systemic change and focuses on cause and effect. How does that translate to safe systems? It emphasizes that multi-sectoral interventions are important. Some have more of an influence on population health than others, and we prioritize interventions on their population health effect and reduction in kinetic energy transfer. How else can we think about this? Think about how we generate traffic safety data right now. We do these backward-looking crash investigations until we find liability, right? We find who's at fault. That's different than cause and effect. As a disease detective, I was taught to go much further back in the causal chain and do that forward-looking risk analysis to figure out the cause of future crashes. And I think that's something that we can all think about today. And when we go back into our workplace, to think about what kind of risk analysis can we do to prevent the cause of future crashes. And so I want to close just with another quote from about public health and engineering and how these folks were thinking. It wasn't so important that the public health engineer know how to build a sewer, is that they know why sewers were necessary and what results may be anticipated from their discharge without treatment into a body of water. Just insert transportation. It's not so important that we just know how to build a road or a sidewalk or a bike lane, but what happens when we do it, right? So many of us can talk about the dimensions or the cross slope, but how many people know that walking and cycling are related to 8 of the 10 leading causes of death in the United States, right? Every engineer should know this. Every engineer should know that the effect of walking or jogging is comparable to the effect of pharmaceuticals in treating depression. This is a randomized controlled trial from the BMJ from earlier this year. So it is a job of physicians to prescribe medicines to help treat depression. And I don't want to minimize that, right? But we have doctors to do that. Our job as transportation professionals is to expose people to the enormous benefits of walking and physical activity to help solve the massive mental health problem we have in this country. And last but not least, good transportation policy is good public health policy. Just this year, we found that Medicaid spending was $90 million less over 5 years than expected after Vision Zero was implemented in New York. So I gave you some of the background, some of the theory, and I hope it was helpful to you. I think you're going to learn a lot from Steph and her work to implement some of these ideas in Colorado. They really are some visionaries and doing incredible work. So thanks for giving me the time, and I hope you enjoy Steph's presentation.
Thanks, Dave. I always appreciate hearing from you and revisiting the concepts that you've presented in the article, you and the team that you worked with, as well as, the way that you share about the Safe Systems Pyramid. I want to thank America Walks for this presentation or this opportunity to present to you all today. And again, to Dave for laying the foundation. My name is Steph Leonard. I am a built environment coordinator at the Colorado Department of Public Health and Environment. My background is in both public health and urban and regional planning, with an emphasis on transportation and physical activity. And so today I'll share a little bit about how we are working towards implementing the Safe Systems Pyramid in Colorado through interagency collaboration. A lot of these efforts started before the Safe Systems Pyramid was proposed. So keep that in mind as we're talking. You know, there's Safe Systems approach, and we're kind of evolving into different models, but we're really grateful to have a new model to look at that's founded in public health principles. So starting off as a background on me, my personal aha moment happened while I was teaching Safe Routes to School programs in Colorado. I viewed this work as public health programming, teaching children ways to live healthy lifestyles. I quickly realized that even if I was able to teach every child in the state the individual skill sets needed to walk and bike safely, they were not ensured a safe journey if the environments and systems in which they lived in were not designed with people actively traveling in mind. So I was seeking a more holistic approach to identify and address the root cause to behind why some of our spaces are not safe for walking and biking. So again, we're grateful for the Safe Systems Pyramid. Often in public health, we have talked about the socio-ecological model as a framework to think about different levels that we should be considering when designing interventions in terms of transportation. We also like to talk about the shared history between public health and urban planning, and kind of a similar origin with diverging paths, maybe. But then, yeah, I think the narrowing in specifically on transportation, knowing that there's a background in engineering at the CDC is just fascinating. But first, I'll touch on the work that we're doing, like specifically within the Department of Public Health and Environment. So in my role at CDPHE, I'm a part of a team that's been working across different levels of the Safe Systems Pyramid for several years by elevating risk and protective factors of transportation systems. So we historically have had a built environment team that focuses on socioeconomic factors in the built environment. And a lot of this work is funded by the CDC through the State Physical Activity and Nutrition Program. So we work with that program to implement state level policies and activities to connect activity-friendly routes that connect to everyday destinations. And then we also have the motor vehicle safety team, which focuses on active measures and education. And does this work by bringing funds from the National Highway Traffic Safety Administration through CDOT's Highway Safety Office and the CDC through the State Injury Prevention Program. And they work to provide data analysis and support community-led strategies to reduce fatal and serious crashes. Recently, we actually internally restructured just teams to unite these two to create a new unit, the Healthy Communities Unit, so we can better align the partnerships that we've been developing over several years, particularly within CDOT, to be able to be more effective in Colorado addressing transportation safety moving forward. So the groundwork for these efforts was laid during the last round of statewide transportation planning, when members of our team partnered with CDOT to inform two overarching plans. The first on the left is the statewide transportation plan, which establishes Colorado's transportation investment priorities and serves as a guide for subplans like the active transportation plan and funding programs like the Safe Routes to School. The current STP is the first version to include language about public health and equity, which was an outcome of a public health, equity, and transportation task force created during that planning process. Similarly, on the right side is a screenshot of the Strategic Transportation Safety Plan, which establishes a mission and vision for transportation safety in Colorado, and it highlights enhancing multimodal transportation safety. That enhancing multimodal transportation safety requires cross-agency and interjurisdictional collaboration at multiple levels, such as policy, planning, funding, design, and construction, operations, and maintenance. And CDPHE was called out as a lead agency in these efforts. So implementing the Safe Systems Pyramid requires regular connection across disciplines, just as the strategic Transportation Safety Plan called out. So we have developed in Colorado the Advancing Transportation Safety Initiative, which is an outcome of that plan. And it is a coalition that comes together to advocate for transportation safety. It consists of 5 emphasis area groups that are centered around the safe systems approach. And these groups consist of state and local agencies, advocacy groups, academic institutions, and private entities. And we actually have a dashboard where we can track the progress of different action areas that have been identified. So on the screen here, it's hard to read, but you'll see things like add bikeability and walkability considerations to the PD 1602 update, which is a policy directive that CDOT holds. And there's been an effort in the last year or so to really strengthen the language to be centered more towards like complete streets instead of just general considerations for biking and walking safety. The foundation of the Safe Systems Pyramid, as Dave noted, is socioeconomic factors. So one way in Colorado that we're considering socioeconomic factors in planning, designing, and funding transportation projects is by using Colorado's EnviroScreen tool, specifically the disproportionately impacted communities data. So just as a quick deep dive, EnviroScreen is an interactive environmental justice mapping tool, and mapping and health screening tool that's managed by CDPHE and identifies areas of the state that meet our statewide definition of disproportionately impacted communities. That was adopted in House Bill 23-1233. And this definition applies to all state agency work. And I won't go into all the specific percentages of this definition, but it includes looking at census block groups and where, for example, 40% of population are low income. It also, on the right side, you'll see like the key or the legend, and these are all different factors that are considered in our disproportionately impacted communities definition in the state. And you'll see the DIC or disproportionately impacted communities referenced in several of the slides ahead, which I'm going to be outlining examples of how we've been actually doing the work, I guess, to align efforts with the Safe Systems Pyramid. Some of these programs and initiatives were in place before the article about the Safe Systems Pyramid was introduced. So, you know, we're still iterating and evolving as we go. One example is the Vulnerable Road User Safety Assessment. So CDOT invited our team to support the creation of this assessment. As context, the 2021 bipartisan infrastructure bill requires each state to identify areas where people who ride, bikes, and walk are at higher risk of being involved in a crash that results in a death or serious injury, and work towards making those locations and populations safer. So our assessment is a high-level plan that considers both safety and equity across the roadway system and uses a safe systems approach, or the safe systems approach, as a guiding principle. And this assessment includes an equity analysis that uses data from EnviroScreen, specifically that disproportionately impacted communities layer, to inform the creation of a statewide high injury network for people walking and bicycling. And this network, like the outcome of the network, includes 39 locations, and 92% of these corridors are located within disproportionately impacted communities. So we're now working to devise plans on how to improve those corridors, and they're both on and off state highway system. Another example is Revitalizing Main Streets, which is a Colorado-specific program that emerged as a COVID recovery initiative and has since been fortified with 10 years of dedicated funding. This program enhances active transportation safety, encourages physical activity, and strengthens the connection of people to main streets by funding infrastructure improvements to make walking and biking safe and easy. Some common interventions that we fund are focused on reducing speed through traffic calming measures, increasing visibility at crossings, and ensuring people actively traveling have quality infrastructure that meets ADA requirements. Our team at CDPHE partnered with CDOT to develop this program and continues to sit on the review committee to offer public health and motor vehicle safety perspectives, and project scoring for applicant or proposed projects includes whether the project exists within a disproportionately impacted community, and that there's like a scale at which we measure equity related to that. So this picture, these pictures on the slide are highlighting a project in Montrose where we were able to fund infrastructure on their main street to kind of slow down speeds and use some best practices to increase the environment for people walking and biking. Another initiative that came out of the most recent state physical activity and nutrition program funding is a mapping project that we've been working on with our partners at Colorado Safe Routes to School and Revitalizing Main Streets. So we have been taking a look at historical funding patterns for both of these programs and identifying where communities have or have not received funding and overlaying these data with the disproportionately impacted communities map for the purpose of ideally moving forward with maybe some more strategic technical assistance opportunities. So we hope to use this information to round out active transportation improvements in Colorado if communities have interest. And for example, this could look like if there are areas that have received funding for new infrastructure, how can the community then create programs that could educate drivers on how to move around this new infrastructure, or people who are moving around actively, how to use it if they've never experienced, a protected bike lane, for example, or a rectangular rapid flashing beacon. And then vice versa, where we know there's interest in educational programming, how could we support communities to then pursue additional infrastructure and environment change that could really bring a more holistic approach to elevating active transportation. So here's a general framework that we're using for the technical assistance that I noted on the last slide. And this is an adaptation of the CDC's Active Communities Tool Action Planning Framework. And we've kind of adjusted it to work well within our Colorado context. So this is still a work in progress and we're expanding, but our goal is to help communities walk along this action continuum to promote safe, active travel, and using some Colorado-specific tools like a community engagement toolkit that we created with the Safe Routes Partnership a couple years ago, as well as with CDOT, and then helping communities understand both qualitative and quantitative data, understand their broader community context, making sure that action planning includes strategies along the entire pyramid and not just, focusing in on one level, and then supporting CDPHE has some funding available to support some demonstration projects, so small scale implementation, but then also encouraging communities to go towards the creation of new plans and policies, as well as pursuing funding for things like revitalizing main streets, Colorado Safe Routes to School, but then also looking at like safer streets and roads for all. And since we are public health, we always advocate for evaluating these approaches. So being available to help communities really understand, are these interventions working? And if they're not, how can we make them work? So we're really looking forward to continuing being able to support local communities. Again, this is kind of a growing effort. So I'll just highlight a related example before closing. Over the last year, the Safe Routes to Parks program has, the Safe Routes Partnership worked with 3 different agencies in Colorado, as well as 4 local communities on the Safe Routes to Parks Activating Communities program. And I wanted to highlight the city of Wheat Ridge. They recently finished up a demonstration project that kind of walked through that framework that I just highlighted on the last slide to really understand their community context, and create an action plan, and then actually got to implement a temporary demonstration project to improve safety near a local park and school. And through this planning process, they advocated for having some of the projects that they identified included in a safer streets and roads for all application that the Denver Regional Council of Governments, our MPO in the Denver region, submitted. And while the community did not receive this funding, they are definitely motivated to continue this work and moving forward to pursue other future funding opportunities. And we're looking for ways to continue working with them as they pursue this path. So thank you again for your interest. I look forward to sharing more in the discussion ahead.
Thanks, Steph. And we're back. And I have changed my background to show the sidewalk project I worked in my neighborhood, in which the sidewalks were an engineering change to make people drive slower. Anyway, Abdullahi, why don't you join us on camera and with the audio and take it away with your first question or two for the panelists. And for folks, there's a bunch of great questions in the chat. I've answered a few of those live. We may even talk about them some more here. And please throw more into the chat. We're monitoring it and we'll get to as many as we can. But go for it, Abdullahi.
Thank you, Mike, and thank you to our wonderful and amazing presenters. This is amazing. This is the type of discussion and conversations that we need to have if we want to see change in our neighborhoods and our streets, and to walk safely without stress and without the risk of being hit by a moving object. So one of the questions that are coming up here is role of governments or elected officials, for example, and things that have to go through this long process of, the elected officials. So I'll read one of those questions. But it speaks to how do we share this information in a way that folks that have that decision-making authority can understand and then make it into a law. Does that make sense, or should I read more about the question?
Go for it. Read the question. Read the
Okay,
question. Read the whole
let me
question.
read the question. So, for example, we're sharing an example from Northern Virginia's program for neighborhoods, where they try for traffic calming. For this particular area, traffic calming is very difficult and time consuming, and it uses voting requirement that none of our the elected officials from that region could pass. Still, those officials won't change it, saying that they don't want to hear people complain about devices in the street. What can we do? So this is the question. What can we do, citizens of that community, to cut through the hypocrisy of saying we follow a safe streets for all program while making safer streets prohibitively difficult to get?
I'll throw it to you first, Dave. What do you think of that when you see that?
Sure, yeah. So this actually happened in my neighborhood in the city I live in. We used to have a traffic calming ordinance where it's still a little strange, but basically you'd have to have a city council rep or council person would have to pass an ordinance to put traffic calming on the street, and then you'd have to have something like 80% of the people sign on to it, which is wrong, right? We do. we shouldn't have to vote or do an opinion poll on safety, right? We don't do that for other things. You know what I mean? So we don't have food safety standards, and we don't say, well, what do you think? Should we? How do you feel about listeria? Should we have that in our deli meats? Right? Nobody does that, and that's because it's a public health issue. And it's the same thing. If we're requiring a vote to have safety, right, we're making an implicit decision to put our kids at risk and we're making a decision to make it more dangerous for kids to walk and cycle. And I didn't feel, and this is outside my professional capacity, I didn't feel that was right. I've got 3 kids. I don't think other people should decide on that. I think safety should be the default. That is a role of government to, be our elected representatives and make sure that at baseline, safety is where we're at, right? If you as an individual want to deviate from that, that's one thing, but you can't expose other people to risk and danger that they haven't opted into. And that's especially important when we're talking about walking and how many kids are walking into our environment. Why is it that the government effectively makes it the default to be unsafe? Right? Because it's a choice. So we shouldn't be voting on safety. How you change that is maybe a different question. But I think people do take an appeal to logic and say, like, I'm not understanding why we're voting to go to the safer scenario. Right. I'll stop there.
I
I'd
would,
love to
Go
throw it to
ahead.
Steph. You're in the middle of everything, Steph. You're in the middle
Yeah.
of the agency world.
right, yeah. So some initial thoughts I had. This is an opportunity for some creative community engagement. One being, to Dave's point, talking about children. I know that there are plenty of really engaged young people in our communities who are reliant on, walking and biking, and also are strong advocates for safer streets. Many, we've found in Colorado, we're actually seeing young people opting not to drive until later on. So, there could be opportunities to engage a coalition of young people to lead some community engagement with those elected officials, and collect some qualitative data in that process, but also this could be a great chance to collect some traffic speeds and real time with the elected officials in those experiences. And then, yeah, I think bringing these data to public forums is important, and incorporating those voices into public forums, recognizing that our next generation is asking for these changes. And while they might not be able to vote just yet, they will be in future, very near future. So creating spaces that people want to continue living and thriving in.
Yeah, absolutely. Thank you very much. This is much harder than it needs to be, but it also involves, being very selective about who we elect, and electing people that care about these issues and can champion safety initiatives in our local city councils. It's one of the reasons I ran, even though I'm city planner, it felt like the elected official was not like on my to-do list in the future, but I had to, because how else can I bring these type of things to the forefront? Again, that is a lot to ask of people to like run themselves or champion, these type of like get involved in the local politics, but that it takes a lot of different things, and also sharing and providing resources like this to people so that they can their elected officials are informed. Mike, would you like to grab the next question?
Let me grab another question, because I think, and
Okay.
I might even I answered it in the chat, but I may just try to answer it here, because
Sure.
I feel an obligation. There were a number of questions in here about that were kind of in the vein of, what's the CDC doing to help move this along? And I think those are really great questions, and I won't put Dave on the spot. I actually get to see a lot of it. We'll get to Dave on it, but I actually get to see a lot of it because America Walks is part of what's called the Active People Healthy Nation program, which the CDC supports. Their division of the division that includes physical activity. And one of the great things about being supported by them is that they have a focus on community design, not just individual and systems change, not just individual behavior change, which is really consistent with the Safe Systems Pyramid. We're funded by them. There's a whole host of organizations funded, a lot of education work, a lot of, you'll see our webinars about how people can connect to funding, and we also provide coaching on that. I think something that really needs to be recognized, though, that CDC is just one agency amongst many others in government, and USDOT has the money. Somebody's asking, what's CDC doing to get money out there for this? There's no comparison between the amount of money USDOT has and the amount of money that CDC funds for Active People Healthy Nation. And that reflects that broader, kind of goes back to that previous question. Why is a safety improvement in the street put up for a vote? There's just this kind of underlying emphasis on moving many cars fast. There's lots of funding for that. There's not nearly the same emphasis on bringing these public health principles to bear. And CDC, in addition to its own programs, also engages in interagency discussions, which they don't share with us, but they are at the table attempting to bring their viewpoint to bear. So, Dave, did you want to add anything to that?
No, that was really super. We're just to clarify, we're not a regulatory agency here, right? There's a big difference between agencies that have regulatory authority and what agencies are able to do. We do have many grantees around the country to do work to make it easier to walk and cycle. That money can't be used to build things, right? That's not our mandate. That's not what Congress tells us to do. So we can work with communities and community organizations, and we do. But we can't build anything. And our budget is a fraction of a USDOT program. Not
Yeah, thank you. Thank you, Dave.
It's okay. I won't tell people what they should do with that information, but they can figure it out.
Okay.
Okay, next question, Abdullahi, throw one at
Yes,
us.
I want to get to this question before we run out of time. We mentioned both people might have been familiar with safe systems approach. It also came up in this conversation. Safe systems pyramid is what we also introduced. So there's a question related to that. Would you say that the primary difference between the safe systems approach and the safe systems pyramid is the much greater emphasis on road/street engineering plus socioeconomic factors with the pyramid? Is that, David, would you like to clarify that and maybe just kind of talk about the two? And Steph, please add to that.
Sure.
If you feel.
so. I'll try to summarize everything really quickly. So the safe systems approach is an old idea, just like Vision Zero is actually rooted in the same principles as the safe systems approach, right? The name Vision Zero is just branding. It's actually a moral statement, not right. That's different. Vision Zero is a moral statement, not a goal. So that's number one. We have to understand that it's a moral statement based on public health ideas, right? We have Vision Zero for cancer, for tuberculosis, for every other health problem. We just don't say it because we don't have to. Okay, so that's number one. Safe systems approach, safe systems pyramid. I think the pyramid was just refining ideas that already existed. One is that kinetic energy is pathologic when it's transferred in high amounts to the human body, right? You want your doctor to understand germ theory, right? That they need to understand that bacteria, viruses cause disease so that they can give you the correct medical therapy or give you a vaccine or the right treatment or tell you to wash your hands. Same thing. For an engineer or planner to understand how to create interventions, they need to understand the pathology, right? You don't want a doctor who doesn't believe in germ theory. And you need an engineer who understands what's at work. Last but not least, a lot of our conversations about safe systems, they imply equivalency or they're descriptive, right? Engineering, education, enforcement, effective in different ways, but not equally effective. And thus, we need to prioritize things differently. So the goal of the safe systems pyramid was to say, we need to think about kinetic energy and we need to prioritize the things that make the most people safe and are effective with the understanding that kinetic energy is what's at work. So the built environment and the socioeconomic factors are always going to influence more people.
Thank you. That is wonderfully summarized, this idea. So thank you very much. Mike, we have 3 minutes and I want to we have a lot of questions. We won't get through it. I just want to make sure we share people next steps and how they find that information.
Yeah, let's do a couple of things. Dave and Steph, if you can hang out, I'm gonna do the close for those of you who have to leave on the hour. And then Dave and Steph, if you could hang around for a few more questions for whoever wants to hang around for another 15 minutes. So that'd be great. So with that, the close is very clear to me. Let's see if I can pull it up. Yes, it's that thing I spoke about at the beginning too. Like all of our work, people, this is a free resource. We have over 1,000 registrants for this. Our ability to do our work depends not just on CDC funding, but on the donations from individuals. And by the way, with that, we can do a lot with those dollars. We had a great Week Without Driving program last month, which I saw you saw. We do a lot of public education. We love doing it. We do a lot of it for free, so to speak, without any grant money at all, because we believe in it. Your dollars will help us and create real change on the ground. We work with local advocates on small community change grants, on coaching them how to get more money, on coaching them how to create change that we've spoken about already. So yes, please, please contribute. We need you to join us. Your dollars will make a difference. Pay attention for our November webinar, and I'll use this to, our November webinar is actually going to be on safer vehicles. There were a number of questions in the chat about what about the size and weight of vehicles, the design of vehicles, particularly the blunt front ends or the sharp edges on certain vehicles. So that is regulated by the National Highway Traffic Safety Administration. They have safety ratings, they have motor vehicle standards. There are regulatory efforts underway that we are pushing. We believe that they are insufficient, but we're going to keep pushing those. We also have something we call the Safer Fleets Challenge, in which we encourage local governments to buy safer vehicles for their own fleets, including intelligent speed assistance, which today we learned that kinetic energy is the primary source of injury here. And we can interfere with that. Put yourself on one of the legs of the epidemiological triad. We can interfere with one of the legs of that by having vehicles that recognize what the speed limit is and stay at or near it. New York City has done that in a pilot. And we are today beginning to encourage the federal fleet, General Services Administration, to do the same. So there's a lot of space in this, and it fits right into the pyramid. So with that, that's our close. Stay tuned for the next one. Become a supporter of America Walks. And I am going to stop sharing. And Abdullahi, pull out another question for our esteemed panelists.
Yes. Well, thank you very much for those of you that are still sticking with us. And I'm not sure the person that asked this question is still around, but this question is for you, Steph. Can you tell us more about who VRU, who it says how, or what, maybe it's what VRU is and how that is impacted by socioeconomic factors and design. VRU meaning probably vulnerable road users.
So our vulnerable road user assessment focused in on people walking and bicycling. But let me pull up, I have the plan. We had a unique definition within the plan. So most typically includes pedestrians and bicyclists. However, we're also looking at, like non-motorized, any kind of mode. So like scooters, I guess that is motorized as well, but like e-bikes and e-scooters, not like a moped. Motorcycles, I believe, were also included within this assessment. And will you remind me of the second part of the question?
Okay. Can you tell us more about VRU and how that is impacted by socioeconomic economic factors and design?
Yeah, so in our assessment in Colorado, we did look at just generally where our crashes were happening for our vulnerable roadway users as defined previously. So where those were happening both on and off CDOT system. So like state highways, but then also local roads were included within there. And so just a general kind of like where are hot spots in terms of crashes in this category, but then did the overlay with our disproportionately impacted communities data to understand, kind of the context of where are hotspots for crashes, as well as, like, does this align with a low income area? Does this align with a tribal community? And trying to look specifically at different sections within those corridors. So like we actually met with all of, this is statewide assessment, but met with the local municipalities in that contained some of our top, like all of our top projects, and separated out by pedestrians and bicyclists. I believe our highway, our high injury network included just those modes specifically. And so just trying to understand like segment by segment within these corridors, what the land use is, some of the, factors that might be impacting the way that people are moving, and had specific conversations about ways that we can be moving forward in each of the different segments within that corridor. So I don't know if that's helpful to whoever's on, and I'm happy to provide more info. I can put I'm sure our emails will be sent out in the follow-up.
Yeah. No, thank you. There were a lot of like questions related to that, like things like, how socioeconomic factors were considered in the development of the safety plan, how can socioeconomic factors be influenced, would it be just limited to policies, questions related to that as well as the VRU specific one. So thank you for touching on that.
I feel like I realize that we're losing our audience here, which is great. So I'm gonna just toss something up. I think I warned our attendees about this earlier. So this is a quiz now for all of the attendees as well as the panelists. If you applied the, let me see. If you applied the safe systems approach to this safe systems pyramid to this educational message from the Colorado State Patrol, which says, remember, when walking face traffic, you'll have a better view of approaching vehicles and more time to move out of the way of a possible distracted driver. Where does this fit on the pyramid? And if you were to apply the pyramid to this roadway, where would you start? I'll go with whoever wants to take this one. Dave.
It's not on the pyramid. Um,
Heavy emphasis on individual efforts.
yeah.
To put
And-
things
Yeah.
in people's cart.
right? Like, I'll put it to you this way: if you stand in the middle of the road and face traffic, you're going to get hit with the same amount of force. You're probably going to get hit with the same amount of force than if you have your back to traffic, right? Doesn't matter. It's not going to be good. So what's going on in that highway? There's some good things and there's some bad things, right? So on an arterial roadway, we have lots of vehicles moving quickly. So we need to separate them in time and space. And how are we doing that in that image? We have a sidewalk, really good start, right? And then the vehicles, they actually, I think there's a concrete median in between them. So that's a good safe systems thinking. We're preventing that head-on collision, but understanding that we have much higher forces at play, much more potential for the transfer of large amounts of kinetic energy. We need way more buffer for someone walking, right? If somebody will go right up over that curve and hit someone, doesn't matter which way they're looking. And honestly, like I want to get upset with that social media manager, but think about how we've educated ourselves in our profession. That person's just doing what they think is best. They have the same goals as we do. And I think it's really important. We're all on the same team. And one of the most important things we can do is have optimism that we can change our own professional ranks, right? Cynicism's easy. It's really easy to be cynical and say like, they're never going to change, right? I think they can. I think folks who are working with state highway patrols, if we start talking to them about this stuff, they'll get there, they'll come on board. This is long-term work, and we have to be optimistic that we can help people develop better messages. So that's how I would apply it is, let's do some education, but let's do it internally with folks that are on our team.
I really love
think
that.
that's a
Cynicism.
close.
I'll just say this and get out of your way.
Go ahead,
Right. No, cynicism is easy, but optimism is really hard, right? If we have to think about the longer, goals and transforming our communities, we have to stay optimistic and keep fighting this fight. Shouldn't be this hard, yes. It's not fair, but this is our reality. So we need that optimism. So thank you very much. That really resonates very deeply.
Yeah. Well, now that you've shared an aphorism, I'll share one too. Being right is easy, right? Just ask anyone. Winning is hard. Takes a lot of hard work. So I really appreciate the notes of optimism.
Yeah.
Go ahead, Dave.
I was gonna say, I think that's part and parcel to public health is that spirit of optimism that we can do this, right? Like a lot of people see the phrase Vision Zero and like, we can't do that. I like being around people that saying we can, that we can eliminate polio, that we can eliminate traffic deaths. And it's hard. It's like you said, winning is hard. And we can. And
Would you
we
like a
will.
last word? Would you like a last word too, Steph? We've all
Yeah,
given.
I really ditto hard with what's been said already. I think like being sassy is fun, but it's also, like the goal is that we're all learning from each other in this process. And, I think like seeing this tweet, I reflect on being at like our safety summit hosted by the Highway Safety Office and being in a room with State Patrol and being in a room with public health professionals and traffic engineers. And like, we're all on this path of learning together. And like, it's, we're bringing different perspectives into our existing knowledge and trying to meet in the middle. And so I think like looking at where we have come versus where we'd like to be, like it sometimes feels like micro changes, right? And very slow progress, but there is progress forward. And very grateful for, even having messaging about the safety of people walking and biking, and, just slowly working on maybe some tone, I guess, moving forward.
Well, with that, we'll close, and I just want to thank all of the people watching for everything you do in your communities. I think one of the real takeaways from this here is hopefully you have something that you can share with your professionals in your jurisdiction, with the elected officials in your jurisdiction, some better ways of talking about it. And, I've been involved in this work a long time. It's about moving the public, it's about moving the agency officials, about moving the elected officials, and it is in fact, more arduous than it should be to put safety at the top of the considerations for how we design our streets. So thank you everyone for all the work you do, and thank you for carrying this safe systems pyramid concept forward in your community. Thanks, everybody.
Thanks all.
Thank you.
Thank you. Take care.